Good morning, and thank you for inviting me to present at this year's DBCC Breast Cancer Update. I'd like to discuss today the current breast cancer screening guidelines. I have no disclosures. Today, what I'd like to accomplish with you is to discuss breast cancer incidence and survival statistics, a brief history and evolution of mammography, screening guidelines for average risk women, and to briefly touch upon the risk assessment models that we use to help define high risk and screening guidelines for those patients who are found to be in that high risk population. Breast cancer is the most common female cancer diagnosed in the United States. Approximately 1 in 8 women will develop breast cancer in their lifetime, and the median age of diagnosis is 63 years old. If we take a look at the graph in the bottom right here, looking at the percentage of new cases and age, we see that the age group between 65 to 74 is the highest percentage of diagnosed patients, with the age group of 55 to 64 being the next highest and composing most of our diagnosed patients. It is believed in the next year we will diagnose 316,950 new cases of breast cancer, with an estimated amount of deaths being 42,000. And this is based on the SEER database. So those cancers overall make up and represent 15.5% of new cancers that are diagnosed in the US. And looking to the future, we see that in the year 2040 is estimated that there will be over 3 million new cases worldwide. Now, if we take a look at the breast cancer survival rates and looking at this graph representation here of the rate per 100,000 persons and looking at that per year, we do see that over the last approximately 50 years that the incidence of breast cancer has steadily inclined. And if we take a look at the light green boxes here, and age adjust for new female breast cancer cases, they've been rising on an average of 0.6% per year over the most recent years that we looked at of 2013 to 2022. If you look at the bottom of this graph and the dark green triangles, that is looking at the death rate. And we see that there has been a steady decline in the death rate. And looking over the years of 2014 to 2023, that has been falling on an average of 1.2% each year. We dive deeper, looking now at the stage of diagnosis and those survival rates. The graph on your left, the pie graph on your left, you can see that most cancers are diagnosed at that localized stage. So about 64% of diagnoses are confined to the primary side of the breast. And the next set of individuals who are diagnosed by stage would be the regional stage, and those are ones that are diagnosed with regional spread to the lymph nodes. And that's about 28% of cancer diagnosis, breast cancer diagnoses. And distant cancers really make up only about 6% of these diagnoses. When we look at distant metastatic disease. And on the graph on your right, and looking at relative 5-year survival, and that is also 5 years and beyond, we see that by stage, if diagnosed locally, we are seeing quite good survival rates, with 5-year survival rates for localized breast cancer being 100% and regional being 87.2%. And that is really due in part to our ability to detect these cancers early. So the impact of that early detection means earlier stage, higher survival, and really less aggressive treatments. So I'd first like to talk about some history of mammography. So the first mammogram was performed in 1913 by a German surgeon, Albert Solomon, and he was using x-rays to really study breast tissue, and this was outside of the body to detect cancer and to see if those x-rays could really give him a good look at the breast tissue itself. And so it really wasn't until the 1960s where we developed the modern film mammography, and that was developed by Robert Egan, a scientist out of Siemens. And this was done in the US, and so this is really what helped form and give the ability to have this widespread early detection for breast cancers, and started to change the landscape for ability for us to treat this disease. And by the 1970s, it started to gain a wider adoption with dedicated machines to mammography. And in 2000, the FDA did approve our first digital mammography system, with 3D mammography then being approved in 2011 and allowing for larger clinical use approximately a year later in 2012, and now really having that dissemination of 3D mammography throughout the US. Now, it really did change in regards from film to digital, and our ability to really evaluate the breast tissue. So if you see in this figure here, figure B is the film mammography, and figure A is that digital mammography, and you can really see the difference in clarity, and really allowing and helping our radiologist to detect these cancers. And so the better detection is really helping us to have fewer false positives. The screening mammogram is quite accurate in that sensitivity being about 84%, specificity of 90%. And with 3D mammography, we see that it does improve sensitivity up to 93% and reducing again those false positives by about 40%. We do see higher accuracy in dense breast tissue. So our screening guidelines for average risk women, and these are the ones that have been developed and recommended by American College of Radiologists and National Comprehensive Cancer Network, as I do know that there is some confusion in regards to who do we follow, what are their recommendations, and so this is where we have developed our recommendations from. And it is that we begin annual mammograms at the age of 40, and we continue screening as long as we are in good health and with a life expectancy greater than or equal to 10 years. And so there's not a specific age cutoff in regards to these recommendations from the American College of Radiologists and National Comprehensive Cancer Network. Now, why do we screen annually? Now, tumor growth rates vary within individuals, and as we said before, annual screening improves early detection, and it does reduce interval cancers. Why do we begin screening at age 40? In the studies that were done to base these recommendations off of, we did see that there's the highest potential for life years gained by starting at age 40, reduces the advanced disease presentation. Yearly screening from age 40 improves detection of aggressive tumors, and that data modeling whether we started screening at 40 or age 50, we do see that it is a reduction in cancer mortality that is more effective than starting at age 50. And we think that there is about a 40% of life years lost to breast cancer that can occur in patients diagnosed before age 50. Now, there are some patients that meet the subset of high risk. And this can be defined as a lifetime risk of greater than 20%. And this is based off of a Tyrer-Cuzick model, which is really the model that most individuals, including breast surgeons and breast radiologists, will use in order to help determine high risk. The other two include prior chest radiation, as defined by chest wall radiation between the ages of 10 to 30 years, and genetic mutations such as BRCA1 or 2, which is defined as high risk as well. A Tyrer-Cuzick model does take into account a family history of cancer in first and second degree relatives. It also takes into account personal history. So if a patient has had a biopsy that demonstrated atypical ductal or atypical lobular hyperplasia, lobular carcinoma in situ, this would be taken into account with this model. It also looks at reproductive factors such as age of menarche, age at first live birth, hormone replacement therapy use, and breast density on mammography. And with these individuals that have a higher lifetime risk of breast cancer, there are additions to our screening, and that annual breast MRI is recommended beginning age 25 to 30. Annual mammogram beginning at age 30. Alternating MRI and mammogram every 6 months. clinical exam every 6 to 12 months. There's discussion for genetic counseling and testing if not already completed. And then discussion for risk reduction strategies, which include lifestyle modifications of limiting alcohol intake, daily exercise, and maintaining a healthy weight. And then a discussion for prophylactic surgical options where appropriate. So in summary, early detection saves lives. Discuss your risk with your healthcare professionals and follow screening guidelines. And of course, if there's any questions, also consult with your physicians. Thank you. And we will now have time for questions.